Hello and welcome to this video module. My name is Guy Young and I'm the director of the Hemostasis and Thrombosis Center at Children's Hospital Los Angeles and professor of pediatrics at the University of Southern California Keck School of Medicine. Joining me today are Maya Bloomberg. Maya is a nurse practitioner who works at the Hemophilia Treatment Center at the University of Miami Miller School of Medicine. And in addition to that is James T. Kenny, who's a pharmacist and MBA, as you can see, and he's the president of J.T. Kenny LLC and the president of the Academy of Managed Care Pharmacy. And today we'll be discussing treatment decisions in hemophilia from evidence to practice. So let's review the learning objectives. Learning objective 1 is where we're going to apply the latest clinical evidence on the efficacy and safety of new and emerging therapies to treatment decisions for individuals with hemophilia. So let's talk a little bit about hemophilia. Hemophilia refers to deficiencies of factors 8 and 9, and both are due to mutations in genes encoding for factor 8, which is hemophilia A, or factor 9, hemophilia B. Hemophilia A occurs in approximately 1 in 5,000 males, and hemophilia B about 1 in 20,000 males. Both are inherited in an X-linked recessive pattern, but it is important to note that about 30% of the patients actually don't have a family history. In addition to the typical pattern of males being the main patients affected, heterozygous females or carriers, they can be symptomatic as well, and we often refer to them as having mild hemophilia, which is the most common form, or rarely moderate hemophilia. The hallmark of hemophilia obviously is bleeding, and in particular, we're talking about joint bleeding because that is where the main damage can occur to patients that can leave them with lifelong crippling arthropathy. So that's really the main organ, if you will, if I can call the joint an organ that is affected by hemophilia. Over 90% of bleeding episodes in patients with severe hemophilia do occur in the joints. And recurrent bleeding into the same joint eventually will lead to the changes that you see in the images below, from a hypertrophic synovitis, so inflammation that leads to enhancement of the lining of the synovium, called synovitis. Then that leads to progressive cartilage degradation, eventually to early hemophilic arthropathy, and eventually end-stage arthropathy, which has very significant impaired joint function. Although I will say that impaired joint function or pain does start as early as with acute bleeding, and particularly with chronic synovitis. But eventually, the joints can be permanently damaged, as you can see in the last image as one example. So I'd like to just use a case to illustrate the different options that we have for treatment and how that may progress over time in a specific patient. So I will use this particular patient. It's a 2-day-old male who was found to have excessive bleeding after a circumcision. There was no family history of hemophilia or any other bleeding disorders. And then at 9 months of age, this patient had a right elbow bleed, which was treated with factor. So that leads us to the question about prophylaxis. Why do we use prophylaxis, and what's the purpose of prophylaxis? And that is nicely illustrated by this data from the Joint Outcome Study, now over 10 years ago that this was published. And essentially, this was a study that was a randomized study comparing prophylaxis versus on-demand treatment, that is, treatment only when bleeding occurs. And it included patients from 6 to 30 months of age with severe or the more severe moderate hemophilia patients, as you can see, factor 8 levels less than or equal to 2%. And again, they were randomized to either receiving prophylaxis at 25 units per kilo every other day versus what was called an enhanced episodic therapy. So treatment for bleeding only when it occurs, but a fairly intense treatment, which included 40 units per kilogram and then 20 units per kilogram at 24 and 72 hours. So an initial dose of 40 units per kilogram, and then 2 additional doses of 20 units per kilogram at 24 and 72 hours. So fairly aggressive management of an acute bleed. And that was to make sure that there was some reasonable way of comparing prophylaxis to on-demand, in other words, on-demand that was treated appropriately. Patients participated in the studies, you can see, for about 4 years, and the main assessment was done at 6 years. And what you can see in the slide below in the table taken from the paper is that patients on prophylaxis, virtually all of them, 93%, had a normal joint as evaluated by MRI, whereas those on episodic therapy, only 55% had normal joints. So already at this very early age of 6 years, you can see joint damage on an MRI in patients who are not receiving prophylaxis. And that's due to the fact that you can see in the next column joint bleeds per year, obviously many more joint bleeds per year in the patients who are on episodic therapy versus those on prophylaxis. You can see an annualized bleeding rate of 0.6 for prophylaxis and nearly 5 for episodic therapy. And if we look at overall bleeds, so all bleeds, not just joint bleeds, you can see again a very big difference of 3 versus over 17. The total use of factor VIII, of course, was higher in those on prophylaxis because they're getting it on a routine schedule. But that's probably a small price to pay in terms of preserving the joint function of these patients. So if we go back to my case, he was placed on prophylaxis with a recombinant standard half-life factor VIII concentrate, and so that was prescribed with every other day dosing, as was in the joint outcome study. And if you look at this slide here, this is essentially a calendar, and it shows you the schedule. And the point is just to show you how frequently in an image that prophylaxis needs to be given. Every other day means basically 15 or so times per month. And if we expand that over the period of a year, it looks like this. And it just gives you the picture of how many infusions are needed and how much of a treatment burden prophylaxis imparts. Of course, factor is given IV, so you can imagine here doing an IV infusion every other day, week after week, month after month, and that's 1 year. And of course, prophylaxis needs to go on and on and on. Otherwise, there won't be the benefits, and the joint bleeds and the joint disease will start to occur, even if you have done prophylaxis for a few years and then discontinue it. And so the point of this slide is to say that that's just the first year, and this has to be continued year after year to continue to prevent the bleeds and prevent the joint damage. Now, back to the case. So this child, due to challenges with frequent IV access, had a central venous catheter or a port placed, something that is commonly done in the United States. Not every center, not every patient, but it is a fairly common practice. Of course, parents really don't like it. Kids especially kind of hate it. And I've had parents send me pictures. And this is a patient of mine. I got permission to use this photo for educational purposes. And you can kind of see the mom drawing up the factor on a sterile field set up on the couch, probably not ideal. And essentially, if you look at this young man's face and his body language, it's telling you that he's none too pleased about what's about to happen. You can see the port sticking out in his upper right chest, his eyes glaring at his mom, his arms crossed. And the mom told me that this happened to be a good day. And actually, after she infused him, she had to go find her other son and do the same thing. So really, the point I'm making here is that after showing you the week after week, month after month, year after year treatment burden, this is a picture that illustrates that it's really not an easy thing to do. So moving on in the case, there were occasional issues in this patient where the function of the port was not working, difficult to infuse. These were treated with infusions or installations, I should say, of alteplase, a clot dissolving drug that is made to dissolve clots in these ports. But eventually, this port no longer functioned and it had to be removed. And at that age, the family decided not to put another port, which I think made perfect sense. And we decided that we were going to teach them how to do venipuncture and access his veins. So at this point, I'd like to turn it over to Maya Bloomberg for some discussion about current and emerging therapies.
Sure. So this slide depicts the current and emerging therapies, and standard of care has long been the replacement of missing factor. With factor replacement, we can either use standard half-life or extended half-lives, and we're seeing a lot more number of both factor VIII and factor IX products that are available for this. But now we're seeing that the treatment landscape is becoming increasingly complex. We're having a change in focus from factor replacement to thrombin generation, and we're seeing products that might mimic the function of factors, such as the bispecific antibodies. We're also seeing factors that are products that inhibit natural anticoagulants, such as small interfering RNA. And the most exciting research and emerging therapy that's being done is on gene therapy, which actually has the potential to restore normal factor production.
Okay, So moving on to a little bit more detailed discussion. So looking here at the new and emerging therapies, we're looking here specifically at factor VIII compounds. And we're looking at both extended half-life factor VIII and factor IX. So I mentioned earlier how challenging it is to repeatedly do these IV therapies. And typically for factor VIII, it's been every other day, and for factor IX, it's been twice a week. So there are several new products available that can reduce the treatment burden by making the infusions less frequent. So you see here in the slide, in the first column and in the top part, are EHL, or extended half-life, recombinant factor VIII. You see the 4 of them there with their generic names. I'm not going to mention the trade name here, but these are drugs that you may be familiar with that you're using in the clinic. The first one, efamerenoctocog alpha, was approved back in, I believe, about 2013, so it's been around for quite a while. And the second one, rureoctocog alpha pegol, was approved a couple of years later. But essentially, if you look at those 4 products, you can see, in particular, I'd like to point out for you the dosing frequency. And you see that they're all a little bit different, but essentially they're not every other day. And you can see that efamerenoctocog, for example, is every 3 to 5 days with some flexible dosing that you can adjust per patient. Rureoctocog is twice weekly. Demoxicog is every 3 to 7 days. And toroctocog alpha pegol, which is the last one to come to market, is every 4 days. So you can see here that all of these are going to reduce the number of infusions, and depending on the frequency of dosing, instead of having every other day, which would be roughly 186 infusions a year, you can see that twice a week, of course, would be 104. Every 4 days would bring it down to about 100, a little less than that. So all of these do reduce the burden of treatment by reducing the frequency of infusions while still maintaining the same level of efficacy as the standard half-life factor VIII. For the extended half-life recombinant factor IXs, there's 3 of those on the market, and you can see that for the most part, they're administered once per week, although they have, a couple of them have some different dosing schedules, which would include every 10 days or every other week. And that reduces the burden even more significantly, and those patients have really quite higher trough levels than we had with the standard half-life factor IXs. Moving on to other types of therapies, so non-factor therapies, there are 2 different sort of varieties. We call one of them non-replacement therapies or non-factor therapies. You see we have NFTs listed there. There's only one that is currently approved. There are others that are in trials. We did only show here the others that are in phase 3 trials currently that we're aware of. So the first one is emicizumab, a bispecific antibody that mimics factor VIII function. It's been approved now for 2 years for inhibitor patients and 1 year for non-inhibitor patients. And most importantly, look at the route of administration is subcutaneous, and the dosing frequency is either every week, every 2 weeks, or every 4 weeks. And for fitusiran, that's a drug that is in phase 3 trials. The current trials are using monthly dosing, again with a subQ therapy. And lastly, concizumab has just entered phase 3 trials as well. So these are all drugs that have different mechanisms of action aimed at improving thrombin generation, and their properties in particular allow them to be administered subcutaneously and relatively infrequently, at least for emicizumab and fitusiran. And then if we move down to the bottom, we have gene therapy. Gene therapy, of course, is aimed at a one-time IV infusion that is meant to, we don't really like to use the word cure per se because we're not sure how long this will last because we just don't have data out that long. But the point is it's meant to be a one-time infusion to correct the factor deficiency and hopefully to correct the factor deficiency permanently. We'll look at some data shortly as we go. And you can see there several are in phase 3 trials and some are in phase 1 and phase 2 trials. And these include factor therapies for both hemophilia B, factor IX, and hemophilia A, factor VIII. So briefly, let's look at emicizumab. Emicizumab is currently approved, as I mentioned earlier. The approval is based on this series of studies called the HAVEN studies. We have HAVEN 1, 2, 3, and 4. And if I can briefly summarize, Haven 1 and 2 were for patients with inhibitors, Haven 1 for adolescents and adults, and Haven 2 for pediatric. You can see the dosing regimens weekly for Haven 1 and several different dosing regimens every week, every 2 weeks, and every 4 weeks for Haven 2. Haven 3 was in patients with non-inhibitors, adolescents and adults, with 2 different dosing regimens. And Haven 4 was specifically designed to look at an every 4-week dosing regimen. All of these studies did demonstrate very significant reductions in bleeding. You can see here results of the different trials sort of put together, where you look at the percent of patients with 0 bleeds in the left figure, and you can see that that starts out in the first 24 weeks at about 78 to 80%, but actually as we go through the trial, you can see that that climbs up to over 90% of the patients that are having 0 bleeds, so not having any treated bleeds at all, bleeds that require treatment. If we look at the patients with less than 3 bleeds, that's virtually 100% and approaching 100% in the last time frame. And if we look at spontaneous bleeds, again, very, very few bleeds, particularly as you go further out in the treatment interval, similar to what I showed you in the slide before. So emicizumab seems to be very effective at preventing bleeding for patients. And again, this is patients with and without inhibitors. If we move over to fitusiran, this is data from the phase 1 study. And what we're looking at here is the ABR depending on antithrombin lowering. So you see 4 quartiles of lowering of the antithrombin from just a little bit of lowering. And again, the goal here is to lower antithrombin a lot. So from a little bit, which is less than 25%, to in the middle, 25 to 50, and 50 to 75%, and to the more significant lowering in the green, greater than 75%. And if you look at the ABR in these patients, the more you lower the antithrombin, the lower that the ABR gets. And again, this is a phase 1 study, so it's not aimed really to look too much at efficacy, but it does give us a hint here that the more you lower antithrombin, the more correction you get of the clotting defect and the less bleeding that you get. Here's the median ABRs, and they eventually go down to 0. If we look at the extension study, this is the phase 2 open label extension study of fitusiran. And what we're looking at is, on this side, patients without inhibitors. And we're going to look at prophylaxis versus on-demand. So we already talked about the importance of prophylaxis. So in the small group of patients who were on factor 8 or factor 9 prophylaxis, they had an ABR of 2. Those on demand had an ABR of 12. With fitusiran, they again had an ABR of around 2. So this shows you that fitusiran is as effective, at least in this small little data set, as factor prophylaxis in preventing bleeding. Perhaps more impressive is the data in patients with inhibitors. Again, it's a small group of patients, but you see the ABR going from 38 before the study to 0, actually, on fitusiran in these patients with inhibitors with a median duration of observation of 6 months. So this needs to be proven in the phase 3 studies, but I think that so far in these studies we see really good efficacy of fitusiran. And then we're going to go over to concizumab, which is the last drug I talked about. This one is now in phase 3 trial. So far we only have data from phase 1, although there was a phase 2 study that was recently published that I encourage you to have a look at. But you're looking at different doses of fitusiran, and essentially what we're looking at is how much can we lower tissue factor pathway inhibitor. And you see here that at the different doses, the more of the concizumab that is given, the more that the tissue factor pathway inhibitor goes down. And the point of lowering tissue factor pathway inhibitor is to, again, correct the defect in clotting. This is similar to the strategy of lowering antithrombin, where we're inhibiting an inhibitor. So I'm going to pass it over to Mr. Kenny right now to discuss, Dr. Kenny, to discuss about how these implications affect managed care decisions.
Thank you, Dr. Young. Certainly there's a challenge for health plans to manage multiple new products, as we saw with the new and emerging therapies, significant number of products coming, requiring a formulary review, decisions on benefit, what benefit are they going to fall under depending on how they're administered, whether they're pharmacy or medical benefit, and obviously increased costs with these newer technologies is expected, as well as the distribution. How are these going to be managed and distributed? Are they going to be through a specialty pharmacy distribution or direct through providers? But ultimately, there's a potential for a significant budget impact for these products coming to market.
Okay, thank you very much. Moving on, what are the implications of the expanding treatment landscape on treatment decision making? Well, as we have more and more treatment options, we obviously have more choices, and more choices for patients, more choices for us to make for patients. So one of the strategies to think about as far as individualizing therapy is to think about the characteristics of the patients and about the different approaches available. So for example, if we look in this table, there are patients who have no issues with venous access or adherence. They've been using factor prophylaxis for many years, maybe even a decade or two. And for those patients, if they're doing really well on factor prophylaxis, certainly you can continue with the factor concentrate. There is no real impetus to make a change for a patient like that. It doesn't mean you can't or shouldn't consider making a change, but for those patients who are doing well on factor concentrate, which is a tried and true treatment, there isn't a requirement certainly to make a change. What about those who are very active in high-level sports? Again, I have patients like that were using factor concentrates on a daily basis when they're participating in sports, and at this point, the other therapies that are emerging make it a bit more difficult, perhaps, to use those. You're not going to use an extended half-life factor every day. It's much more costly and not necessary in a situation like that, where you're giving a standard half-life factor every day. And we're not really sure how well drugs like emicizumab, fitusiran, concizumab are going to protect patients who are active in very high-level sports. But in addition, there are patients who are risk-averse. The hemophilia community has had very significant impacts from therapies in the past, and overall remains, generally speaking, a risk-averse community. So there are those who may not want to try new therapy. So we shouldn't forget that factor therapy is tried and true, it's effective, and if given in the right manner is a really excellent therapy. However, I mentioned earlier about the treatment burden and the difficulty with having to do IV over and over again, and that leads us to this next category of patients who have poor venous access and or poor adherence, so they're not getting effective prophylaxis. You might want them on prophylaxis. You might prescribe them IV prophylaxis, but they're not doing it, either because they can't because of their venous access issues, or because they're having significant issues with adherence due to a combination of the time, the effort, and perhaps the venous access as well. So such patients may really benefit from a subcutaneous treatment. And we'll come back to the case that I mentioned earlier and discuss that. And then ultimately, some patients just really want enhanced convenience. I showed you in those calendars how doing prophylaxis with IV factor, even if it's an extended half-life factor VIII, where it's every 3 days or every 4 days, still is very burdensome because it's IV, and so it's still going to be about twice a week. And so for some of those patients, the convenience of a subcutaneous therapy once a week or less often really holds a lot of value. So those are patients that you could consider in addition one of these subcutaneous therapies I mentioned. So I'll move over to Ms. Bloomberg again to discuss some of the nursing perspectives.
Sure. So as nurses, we play an integral role in maintaining patient education, maintaining close contact with their patients. So a lot of education goes into this, and one of them being managing different side effects. So we see that the most common side effects for products, whether it's factor replacement given IV versus the newer subcutaneous medications, is an injection site reaction. And most of these reactions are transient. They resolve within the first hour and don't require any intervention. Many other common side effects include allergic reactions, headache, or not. But it's something to be aware of and make sure that you're educating your patients on what they can expect with regards to their treatment options. Dr. Young had shown previously the progressive effect of hemophilic arthropathy, which is a big complication that unfortunately we're seeing more of, especially for our patients who didn't necessarily benefit from factor prophylaxis. And he pointed out how the recurrent bleeds cause that chronic synovitis, the inflammatory arthritis, and progressive arthropathy, and therefore prevention really is key, and we do this by using prophylaxis. It's extremely important to recognize these bleeds early and initiate early treatment. And exercise and joint therapy is another method to help with prevention. And many times people think that exercise can actually cause more bleeds, but it's actually the opposite. When you really are focusing on strengthening that joint and all of the supporting structures, the frequency of bleeds decrease. And if somebody does experience a bleed, it usually resolves much faster. So this ties into physical therapy. So we can use a physical therapist to help with the acute management of bleeds, but they can also help with that long-term management and exercise and joint strengthening. They can help create home exercise programs in order for you to do this. It's also important to have ongoing assessment for pain, because you can imagine either in the acute bleeds that can be extremely painful, but our older patients with significant hemophilic arthropathy and severe joint damage, they can be living a life with a lot of pain. So making sure you're assessing your patients and appropriately managing that is ultimately going to improve your patient's quality of life. Ultimately, for hemophilic arthropathy, joint replacement might be that gold standard, gold treatment if quality of life is impacted with the daily pain, severe limitation of motion, and this is where collaborating closely with an orthopedic surgeon is extremely important. The most important adverse event in hemophilia treatment is the development of inhibitors or alloantibodies, where any infused factor replacement is going to be rapidly eliminated from their body, thus reducing or neutralizing the efficacy of the product. We see this happening in around 30% of patients with severe factor VIII deficiency, and it's usually highest risk in that first 50 exposure days. And it's much less common in our hemophilia B patients, occurring in 3 to 4% with those with severe factor IX deficiency. We see that developing inhibitors has a lot of impacts on these patients. It can shorten their life expectancy and reduce their quality of life. There's a lot of complications both with surgery and outside of surgery. They're at higher risk for more severe bleeds, such as the intracranial hemorrhages or orthopedic complications. And there's a significant economic burden because these treatment options that we have are extremely expensive and can take a toll on the patient as well. Typically, the gold standard has been to eradicate the inhibitor using immune tolerance therapy with the use of bypassing agents to actually treat bleeds. But it's important to point out that these bypassing agents only have a 75 to 90% efficacy in actually stopping an acute bleed, and it does carry a risk of thrombosis. So this is where the expanding treatment landscape has had a significantly positive influence on this population of inhibitors, because with the addition of emicizumab, we now have a product that we can rely on and trust for prophylaxis, where it significantly reduces the bleed rates that they're having, and a lot of patients report less pain and less bleeding episodes on this product as well. Some special considerations to take into account for are women with bleeding disorders. So Dr. Young previously mentioned that we used to refer to them as carriers or symptomatic carriers, but we're having a shift now of actually calling them mild hemophiliacs and less commonly moderate, depending on their factor level. Many of these patients will require treatment for surgeries with factor replacement, and extended half-life products have been a good addition to this population for patients with heavy periods or menorrhagia, because you're able to infuse factor on that first day of their menses, and it stays in their system long enough to cover for their highest bleeding days. There's also the addition of emicizumab, and the FDA approval actually doesn't specify a severity. So if you have a female patient who happens to be having a lot of bleeding, it's something that you could consider as well. I just went over the inhibitor patients, but our aging patients with hemophilia is another consideration to take. We're seeing the advancement of all of these treatment options in hemophilia, that our patients with hemophilia now have a life expectancy that of the general population. And because of that, we're seeing a lot more age-related clinical conditions. A lot of our older patients had contracted hepatitis C infection, which led to cirrhosis or the possibility of liver cancer, and this could cause additional bleeding issues. We talked about hemophilic arthropathy and the progressive joint disease that we have to take special consideration for. A lot of these newer treatment options, patients have actually been able to report resolution of their target joints and less pain. We're seeing a lot more cardiovascular disease and hemophilia patients possibly requiring antiplatelet therapy or anticoagulation. So you might have a mild to moderate patient who never required prophylaxis their entire life, but now that they're being put on blood thinners, we have to start considering what treatment option might be best for them. And lastly, we know the probability of cancer increases as one ages, and depending on the treatment options for this, they might receive chemo or other agents that will increase the risk for bleeding, and they might need a different hemophilia treatment option that they otherwise haven't been exposed to in the past.
Great, thank you, Maya, for that very nice overview of those topics. So let's go back to our patient case. So in this case, we taught the parents venipuncture. If you remember, this was a 9-year-old whose port wasn't working anymore, and who was on a standard half-life factor VIII product. So initially things go very well, but over time, over a period of some months, it gets more and more difficult to access his veins. And for that, the parents sent me another picture, and you can see here 3 Band-Aids, 3 bandages on his arms. And the important point here is that that was for 1 infusion. So it became increasingly difficult to manage this patient with IV factor of any kind. We even switched him to an extended half-life factor VIII, but it didn't really make things much easier because going from every other day to twice a week still was very difficult to access the veins. He started to miss doses of factor, and he started to have some bleeding events, which he had not had before. So it was really quite unfortunate for a patient who'd been on prophylaxis, essentially not having bleeding for most of the first 9 years of his life, and now all of a sudden bleeding, mostly because of a venous access issue. So once emicizumab became available, we did prescribe it for him, and the family agreed with that option, and we decided to go ahead and use that for him in an effort to give him prophylaxis and overcome this venous access issue. So let's look and see how that might impact on how payers might look at this.
Well, clearly from a payer perspective, we want products with good efficacy, safety, dosing, those that are going to be well tolerated. But we also have to try to balance the cost as well. As we move from short-acting or shorter half-life products to longer-acting half-life products, we want to make sure that these are going to be dosed appropriately. And we don't see somebody on an extended half-life product getting it every 2 days when it could be dosed every 4 to 5 or 6 days. So clearly that's an important piece for the plans. And ideally, we want to match the best product for the patient to get the best clinical outcome and avoid those adverse medical events, whether it's a significant bleed or whether they require additional medical resource utilization, an ER visit, a hospitalization even in the worst case, but also to try to do it at the lowest cost.
Okay, thank you. So just to close this section, we want to review SMART goal strategy, which is to look at specific, measurable, attainable, relevant, and timely therapies and timely goals and timely evidence. So the important thing for you is to stay up to date on the latest evidence because things are changing really very quickly. There are new data that are being published probably every month at least with respect to all the treatments we talked about earlier. So it's important for you to stay up to date on those and to utilize the latest clinical data to individualize treatment plans for patients with hemophilia. And so with that, we'll close this section.